To welcome today wonderful physician and speaker. Dr. Gaetan Moise is a clinical instructor of neurological surgery of the New York University Langone Hospital and Neurosurgeons of New Jersey. And he's here today to talk to us about spinal stenosis. Thank you so much for joining us today, Dr. Moise.
Oh, my pleasure. And thank you, everybody, for hopping onto this Zoom. A lot of topics to cover in a really short period of time. If you guys have any questions, just like Sue said, just put it in the QA and we'll try and get to as many of those at the end as we can. So let me start by going through and talking a little bit about what the outline is going to be of the talk. So we're going to talk a little bit about anatomy. We're going to define spinal stenosis. We're going to talk about what the typical patient who has spinal stenosis looks like, how as physicians we do a workup to figure out the cause of the problem, and then figure out both non-surgical and surgical treatment options. So the first thing to do is to talk about some vocabulary. So stenosis is just the medical terminology for narrowing. So in this case, we're talking about the narrowing of the channels in the bone along the spine where the nerves or spinal cord run. And a useful distinction medically is between acute, subacute, and chronic. So acute is anything that's happened that's only lasted 6 weeks or less. Subacute is anything that's been going on for about 6 weeks to 3 months. And chronic is anything that's been happening for more than 3 months. The most classic term that you hear associated with stenosis is claudication or claudicatory, and it just means activity-based symptoms. So if a symptom goes away when you're resting, whether it be lying down or sitting up, and activates when you're standing up and walking or doing some other form of activity, that's claudication. Radicular or radiculopathy, which you'll sometimes hear, refers to the symptoms that arise when an individual nerve is compressed. So for example, sciatica, where you feel pain shooting down the back of your legs, is a compression of the sciatic nerve, which sometimes happens in the spine, in which case it's a radiculopathy. And then cauda equina is literally Latin for horse's tail and refers to the bundle of nerves that we find in the lower portion of the spine. This is sort of the anatomy that we're talking about, and as most of us are aware, the spine is divided into different sections. Cervical and thoracic refer to the neck and the middle portion of the spine where the rib cage is, whereas the lumbar spine refers to the lower back, where the majority of stenosis problems arise. Generally speaking, stenosis problems that involve the cervical or thoracic spine involve spinal cord compression, and the conversation is typically very different because that tends to cause progressive problems. In the lumbar spine, where you're compressing that cauda equina or that bundle of nerves that I mentioned, the symptoms are usually much more insidious or slowly developing, and usually affect quality of life less than functioning, at least in the early stages. There are multiple muscles that connect to the spine as well, but those are less relevant from our standpoint. So if we think about what it means when you have stenosis in the spine, it really depends on where the problem is occurring. If it's in the neck or cervical stenosis, then you can potentially have both the arms and legs affected because the nerves that go to the arms haven't left the spinal canal yet. Generally speaking, for lumbar stenosis or stenosis in the lower back, the legs are only affected because those are the only nerves that are left. Technically speaking, there are also nerves that go to the bowel and bladder sphincters, so that can be affected in very rare circumstances. So this kind of gives us a little bit of a cartoon of what's happening at each level, and what they're showing you is at each level there are these little individual nerves that exit between the bones from the central canal. And they've just color-coded this to kind of give you an idea of where the neck, thoracic, and then lower back regions really run. So what does classic lumbar or lower back stenosis look like? So generally speaking, insidious onset, meaning it comes on very slowly. It affects the lower back and legs and has this claudication appearance or activity-based symptoms with either pain, heaviness, or numbness with standing or walking. The symptoms go away when you sit or lie down. And patients will oftentimes find that bending forward helps, which often leads to a position where either the patient is using a shopping cart or a walker to help them walk longer distances. The main response that most patients have to stenosis symptoms is to become more sedentary. So as it becomes more painful to stand or walk, and people are generally trying to avoid pain, most patients will end up starting to sit and do less. So the classic cartoon of this is somebody stands, they start having pain, they sit down, it goes away, and then they get up and walk again. So I have patients who will say, you know, I used to be able to walk 2 miles. Now every 50 feet, I'm looking for somewhere to rest because my back starts acting up. So if this sounds like you, the question is, what are we supposed to do about it? So when you go and see the doctor, typically you'll get a history and physical where there's both a self-administered questionnaire as well as some history taking, finding out how long this has been going on for. Are there any concerning findings such as signs of infection, signs of cancer, et cetera. And then the physician will usually do a physical exam, mainly designed to both confirm that the problem is located in the spine and to rule out other potential causes that can give you a similar presentation, such as vascular problems or problems with blood flow to the legs or back. There are clinical diagnostic criteria that we use to sort of classify things as lumbar stenosis before we have the imaging, and some of those things I've already mentioned here. And when we're thinking about what's called a differential diagnosis, or what are the other things that this could be, it typically falls into a few categories. The first and most obvious one is blood flow problems or vascular claudication. So oftentimes, if we get imaging and the spine is not very revealing, then we'll send patients to a vascular specialist to make sure that there's not some blood flow problem, either on the arterial side, which is sending blood to the legs, or the venous side, which is bringing blood back. In theory, you could have a problem just above the lower back in the thoracic spine region. This is typically not very common because the rib cage holds it together, and so there's not a lot of movement in that area. But when the lumbar spine or lower back is completely clean, then we'll start looking in those areas. And then you can have things that mimic these problems. So people who have hip or knee problems, people who have problems with the nerves outside of the spine, or in rare cases, metabolic problems. So for example, there are medications that can cause damage to the muscles, which result in a condition called rhabdomyolysis, where patients will present with pain and weakness, and it's really secondary to a breakdown in the muscles, secondary to exposure to a medication like statins, for example. So when we think about claudication, claudication is related to neurological compression of the nerves. Pseudoclaudication is related to vascular problems. And so these are the kind of factors that doctors will use to distinguish between those two things. So when we're thinking, how do we evaluate these kind of spine issues on an imaging basis? First study almost everybody gets is an X-ray, and that's really because that gives you a quick and easy way to look at the alignment of the spine, to assess for the degree of arthritis that's developed, and to look for any potential clues to an area that might be worth looking into in greater detail with more advanced imaging. MRIs are kind of the mainstay these days. They give you a nice soft tissue description of the nerves, the discs that are made of cartilage between the bones, and can really accurately diagnose most causes of stenosis. And you get multiple views that you can use to look at a granular level at individual levels. A less commonly used technique is something called CT myelogram. This was MRI before MRIs were invented. They're a little bit more invasive because they involve a radiologist having to inject dye into the spine and doing a CT scan. There are some patients who still qualify for CT myelograms. For example, some pacemakers that are not compatible with MRI because the magnet, it puts the pacemaker at too much of a risk, will get CT myelograms, although that's becoming less common. Also, patients who've had prior surgery, and so therefore the MRI gets confused by the metal that's present in the actual imaging field, may benefit from a CT myelogram as well. So this picture here shows the normal MRI on one side, and then an area where the canal where the spinal cord is running and the nerves are running is compressed. So this is what things should look like, with nice straight lines, lots of white space for the nerves to slowly free to spin in. And here you're seeing an area where there's a lot of black density, which in this particular case is overgrowth of a ligament compressing the spinal canal. So things that can cause lumbar stenosis are basically arthritic changes, so bone spurs, overgrowth of that ligament that I mentioned, pieces of disc that push out of position, malalignment problems that affect the global alignment of the spine, such as scoliosis, instability in the spine or weakness. Some patients will have what we call congenital spinal stenosis or narrow canals to begin with, and then much less common things are things like infections and tumors and cysts. This gives you a little bit of an overview of those different things. On this end, there's a little herniation, which is causing some narrowing. Here, this is a malalignment, which is causing some narrowing. At this third picture, this is a little cyst causing some narrowing. And here, this is arthritis or degeneration of the disc between the bones that's causing some narrowing of the space where the nerves are trying to exit. From our perspective, timing matters, because in a case where you have a fracture, or you have a blood clot, or you have an infection, that can lead to rapid compression of the nerves and paralysis and dysfunction of the sphincters. Most stenosis is not acute stenosis like in these pictures. It's chronic stenosis where it's developed over months or years, and so therefore just causes the pain symptoms or the heaviness symptoms, but doesn't ever put the patient at risk for paralysis. Other tests that your doctors might suggest include nerve testing, testing of the muscles or EMG, and then ultrasound of both the arteries and the veins in the legs. Like I mentioned before, there are some conditions that you can find on lab results that can give you sort of similar picture, even though it's clearly not stenosis. So from our standpoint, the most important thing is what is an indicator that potentially treating this without surgery is going to result in success. So the best indicators for this are if your spinal alignment looks normal, if your symptoms are mainly in the legs, if your symptoms have only lasted for a short period of time, less than a year, then most patients will get at least some initial benefit, and up to 40% of patients with that presentation can get long-term relief without having to do surgery. So going through the different avenues of non-surgical options, chiropractic manipulation, where they're applying forces across the spine, turns out to be just about as effective as physical therapy. Generally speaking, we think of physical therapy as an intervention that you do for a specific problem, whereas a chiropractor usually has a longer term relationship to help manage the problem over a longer period of time. If you do a chiropractor and it doesn't help, that's when the Valley Spine Center comes into play. It's a multidisciplinary center that has neurology, radiology, PT, pain management, rehab medicine doctors, and the spine surgeon specialists as well. And typically you will go through that in a stepwise fashion, with hopefully the spine surgeon being the last person you see, and hopefully never at all. They have diagnostic imaging. They've got the ability to test for the nerves. They have spine fitness programs, acupuncture, and biofeedback. Generally speaking, we try and keep patients out of the operating room. So for mild symptoms, it's strictly non-operative. For moderate symptoms, you're trying non-operative treatments and surgery only for patients who fail that. And then in severe symptoms where the patient either cannot do physical therapy, can't tolerate these non-operative maneuvers, that's where surgery sort of becomes the primary method of treating. So things that patients will talk about: bracing. Generally speaking, bracing can help in the short term, but it tends to weaken core muscles. So long term, we try and avoid the use of bracing because patients become very dependent on it. Physical therapy usually will last 6 to 12 weeks and has a very good success rate in the initial phases. Up to 75 to 80% of patients with those initial symptoms that I mentioned to you will get benefit for at least 6 months to a year with a trial of physical therapy, which can always be repeated if the symptoms start to recur. If that's not working, then that's when the interventional pain management team at Valley Hospital becomes critical. Currently, there are 3 doctors on staff, and a 4th one is set up to join very shortly to meet a growing need. And these are the doctors who will provide both medications, which tend not to be particularly effective when it comes to spinal stenosis, and interventions such as epidural steroid injections. They are trained in anesthesiology, internal medicine, and physiatry, and then they do a subspecialty in pain management. And the docs here, that's all they do. All of their procedures are same day, meaning you come in and you go out the same day, and they offer complementary medicine alternatives like acupuncture, which I mentioned. So the most common interventional treatment for stenosis is an epidural steroid injection, where they're placing a needle under X-ray guidance right outside of the canal to put steroids in, with the hope that putting the steroids will reduce the inflammation around the nerves, maybe shrink a little bit of the inflamed tissues, and give a couple of extra millimeters of space and less reactivity to the nerves, so that functionally patients will see a significant improvement in regards to their ability to stand and walk. You can get about 6 months worth of relief. It's unclear long-term whether you can use it to effectively avoid surgery. But most people would say if you do less than 3 injections a year, then that can potentially be a good long-term strategy. Most of the patients that I see in my office who end up having surgery have managed their stenosis for months to years with a combination of physical therapy and injections before those things start to lose their efficacy. Acupuncture can be tried. There's no definitive data that shows that it works, but generally speaking, it's safe. So I always tell patients, if it's something that they want to try before they start committing to more procedural-based options, such as injections, it makes total sense to me, as long as they're not spending months and months doing it with no benefit or spending thousands of dollars. If none of those things are working, then that's when we start shifting to the idea of minimally invasive spine surgery. So this is the team at Neurosurgeons of New Jersey, who all specialize in minimally invasive spine surgery. Most common questions involve, am I a candidate? Am I going to be paralyzed if I have surgery? Am I going to risk damage if I don't have surgery? And then questions like, what's recovery like? How successful is it? And do I need a fusion? I'll try and run through those really quickly. Most people are a candidate. Exceedingly rare to see any sort of nerve damage with surgery, especially since for the lower back or lumbar spine, we're dealing with individual nerves, not the spinal cord. Most people with lumbar stenosis do not risk damage if they don't have surgery, and a lot of these surgeries can be accomplished without having to fuse patients at all. Recovery is a lot better because of the minimally invasive approaches that we have, and the minimally invasive approaches tend to be just as successful as the open procedures, where you're seeing success rates of between 80 and 90%. And the procedures that we do really depends on the type of stenosis that the patient has. The nice thing about minimally invasive approaches is that it reduces blood loss, gives shorter hospitalizations, and a lot of these things can be converted to outpatient procedures where you go home the same day. Use less pain medication, which has been a big issue for medicine in general, given the fact that we know the effects of these opiate pain medications on patients' pain tolerance levels and complications. They can return to work quicker, the incisions are smaller, and the outcomes are equivalent. For herniated discs, we can operate through a tiny port, literally 14 millimeters in diameter, and do everything that we need to remove that. This is an example of a herniated disc here. For buckling of the ligament like this, we can go in with that same port and remove that. We can also place interspinous distraction devices that separate the bones and therefore cause that buckled ligament to straighten out, which can also help reduce stenosis in very specific cases. For patients who have multi-level disease, these minimally invasive approaches are nice because you can angle the tube in different directions and get each level so that the overall incision is smaller, but you've still treated the disease at every single level. This is what our open procedures used to look like, and this is what our minimally invasive procedures now look like. So big difference in terms of the size of the incision, the expected blood loss, and the postoperative pain. For patients who have malalignments like this is where you actually have to fuse a patient. So you can imagine in an MRI like this, where the bone is completely shifted forward, which you also see on the X-ray, you really need to pull those bones back into position in order to get an adequate decompression of the spine. But we can also do those kind of procedures through a minimally invasive approach through the tubes with great success. So this is an example of one of these minimally invasive fusion surgeries, which gives you the same benefit of shorter procedure time, less time in the hospital, and less pain medication use afterwards. This is another version of those spacers that I mentioned to you that we will sometimes use in patients who have a little bit of a malalignment to try and prevent that from getting worse, so that we're not doing a complete fusion on patients. And what you generally see with the data is it's a shorter procedure than the actual fusion. The hospital stay is shorter than a fusion. And because it's not actually locking those bones together, you do preserve some motion across that segment. This is a special kind of fusion that we do for advanced degenerative changes, where you're trying to open up the space where the nerve is exiting by putting a spacer in between the two bones to reestablish the normal height. We also have a specialized kind of device that can open up that space by essentially shaving the underside of the joint without actually having to remove it completely or put in that big spacer, something called a foraminotomy. That can also be done through that minimally invasive approach. The nice thing at Valley is that we've got a lot of technology. So besides those devices that I showed you, there's an intraoperative CT scan, which helps with localization, placement of any instrumentation that we have to do. We have intraoperative navigation, so we can actually see where we're putting the instrumentation in as we're doing the procedure. We've got neuromonitoring, so they're testing the function of your nerves as we're working, so that we know that we're not causing any damage with any of our maneuvers. And we also have a neurointerventionalist team that is there to provide us with support for patients who have things like compression fractures, where they can do kyphoplasties in their hybrid operating suite, where they have x-rays in multiple planes to be able to put in balloons and glues and cement to reestablish the normal height and shape of the spine. So questions that you should be asking your surgeon if you get to the point where you're thinking about surgery is, how many of the surgeries have you done? Do you specialize in this kind of surgery? Are there alternatives to the surgery? Because a lot of surgeons have trained one way, and then once they get out into the actual real world, they don't continue to update their techniques. Or some people will be very rigid in regards to their approach. But for most things that involve the spine, there are probably at least 2 and maybe even 3 alternatives to that surgical approach that are worth considering. And then, of course, asking neighbors, friends, family, et cetera, who've had problems with their back surgery in order to kind of get a full picture of what recovery looks like. All of this stuff is available at the Valley Hospital. They've got the comprehensive spine center, the O-arm, that CT scanner I mentioned, the navigation, 3D microscopes, access to every single minimal spinal access system available on the market, and neuromonitoring. So they're capable of meeting every need that you have, both non-surgically and surgically. So the big takeaways from the talk should be that mild symptoms can and should be managed without surgery. Moderate to severe stenosis does respond well to surgery, and there are minimally invasive options for that. But generally speaking, surgery should only be considered if the non-surgical options have failed and your functional status or quality of life are significantly impacted. Surgery should definitely be tailored to the individual, and that includes using the imaging, the symptoms, and their specific factors, including health and activity goals, to decide on an appropriate treatment course. And no surgery should be chosen because the surgeon doesn't know or doesn't have access to the newest techniques. This is the team at Valley Hospital that's committed to making sure that your back is as healthy as possible. Thank you.
Okay, that was wonderful, doctor. Is there, please forgive me, but do you have a phone number or some way to get in touch with you in your office?
Absolutely, yes. So I'll make sure to send that out to you so that maybe you can append that to the back of this talk. But our direct number is 201-327-8600. And our office is right by the duck pond. I'll also make sure to get you guys the number for the Valley Spine Center, which has a great access navigation system to help get you to exactly the right person.
Okay, that is so great, and I'll send that out too. Thank you so much. This was great. Just a few questions. I don't know if you already touched upon this. What if you wait too long? Like if you have a high tolerance for pain or just discomfort, and you wait a little bit too long to have the surgery, or longer than you might recommend?
Good question. So generally speaking, there's no such thing as too long, except in one circumstance. So what the studies clearly show, and why we always say that surgery should be the last resort, is that if you do surgery when the symptoms first start, or you do surgery after you fail non-operative management, the outcome is the same, meaning the nerves are very resilient. So if you do the surgery and you free up the nerves and you achieve what you want to in the surgical case, then you will do just as well as if you did it originally. So from our perspective, that means you should try everything first and keep surgery as the last resort. The one circumstance where that's not the case, but usually these things kind of intersect, is if you run into a major health problem that arises that makes the surgery much more challenging. So for example, if you had a major heart attack, right, in the midst of trying to treat your lumbar stenosis, and now you've got a much higher risk of being under general anesthesia, then the risk reward starts changing in regards to doing the actual surgery, but it doesn't actually change whether or not the surgery would be successful, as long as you don't run into complications. But if you ran into a major health concern, then usually the stenosis symptoms become less of a concern, because you need to deal with this other issue first. So I'd say there's almost no circumstance where you've taken yourself out of the contention for having surgery just by waiting. In fact, it's typically the best thing to do. There is one consideration that, we used to say that this is a purely quality of life issue, but what we know more and more is that a sedentary lifestyle leads to health complications, right? You gain weight, right? You can develop weakness in the muscles as a result. So you can develop, problems with your labs that can increase your risk of heart attack and stroke. So generally speaking, if you wait till the point that you're starting to have negative health outcomes because of it, that's probably not beneficial. So I do advocate for most patients, don't give up the best years for the worst years, meaning don't say, I'm going to wait until I absolutely can't stand this anymore before I opt for treatment, because you're taking healthy, good years and you're making those years the years where you suffer with symptoms. And then once you've reached the absolute limit of your tolerance, then now you're older, you may have run into health complications as a result of, trying to manage this without engaging in the health system. And that's probably less advantageous overall.
And that's even if the person ran into like almost being paralyzed from the stenosis?
So that's completely different. Yes.
Okay.
So for patients who have acute spinal stenosis, there's no even option of waiting. You're coming to the hospital because you can't move your legs. So that's like a completely different category. So the way I would put it is, patients with classic lumbar stenosis that's gradually occurring almost never develop paralysis. Like, it just doesn't happen. So that's why we feel comfortable leaving surgery as their last result, because those patients will have a ton of pain. They may even say, you know what, I don't get up and walk anymore because it's painful, but they almost never say, I don't get up and walk because my legs don't move. And, from our perspective, that's the major dividing line, is if a problem is going to lead to progression and irreversible damage, then surgery becomes an upfront issue. And that's where neck stenosis or cervical stenosis, or stenosis in the thoracic spine where your rib cage is, I didn't even put in this conversation because it's a completely different presentation, and much more frequently surgery is kind of very much at the forefront of treating that. But for lower back stenosis, I'd say it's much less than 1% of patients who even present with any consideration of paralysis.
Okay. What about in neck lumbar? Is that different?
Yes.
Okay.
Absolutely. So patients who have cervical stenosis or neck stenosis, they will oftentimes have symptoms in the arms and legs, and they will present with coordination problems, clumsy hands, difficulty walking, which involves balance issues, weakness, inability to feel certain segments. And those symptoms are not claudicatory or activity-based. They're persistent all of the time or constant, and they progress with time because it's the actual spinal cord that's being damaged. So those kind of symptoms will often prompt immediate imaging of the cervical spine. And if you see actual compression on the spinal cord, you will be seeing a surgeon, and it's highly likely that they're going to recommend surgical intervention.
Okay, so do you think that like lumbar stenosis or any of these stenosis are genetic?
Good question. So to some degree, yes. So there are patients who have that congenital spinal stenosis that I mentioned to you. Congenital just meaning it's been happening since development or at birth. And you will definitely see that run into families. And the way that that really impacts things is stenosis refers to narrowing the space sufficiently that the nerves don't have sufficient room. I've seen patients with canals that are massive in size. And so you could have a large disc herniation or a significant malalignment or a big piece of bone spur in the canal, and it's still not hitting any nerves. Somebody who has congenital spinal stenosis basically has just enough room at baseline for their nerves. So anything that encroaches into that space, even if it's small, is going to press on a nerve and is likely to cause symptoms. So there's definitely that genetic component. But I think in general, the more common thing to see is people who have a genetic predisposition to developing arthritis in their spine. And the more arthritis you have in your spine, the more likely it is that at least at some level, it's going to combine both from the front and the back to create an area where the nerves are actually being compressed.
Okay. If someone's taking statins, does that affect someone who has spinal stenosis, to your knowledge?
Generally speaking, it shouldn't. It is known that statins can cause rhabdomyolysis in rare cases where it can affect the muscles, so that the combination of a little bit of spinal stenosis and a little bit of muscle damage from the statin can make the presentation more obvious, but it's not the statin actually making the stenosis worse. It's more like it's making the symptoms more obvious because it's affecting the muscles.
Okay. Somebody who's had stenosis surgery, someone said DF surgery. Does that make sense?
Yeah,
okay.
Absolutely.
And has osteoporosis. Can the individual exercise without further injuring the disc? Because obviously exercise is important to osteoporosis.
Absolutely. So yeah, so if the surgical area has healed, and that process can take essentially 3 to 12 months to confirm that you see full bone growth across the graft. And ACDF is just an anterior cervical discectomy infusion. So we're locking two bones together in the neck to provide relief of symptoms. As long as that area has healed, then exercise is completely fine, because once the bone has grown through that area, it's actual healthy bone that is holding things together, and the instrumentation is not even playing any role anymore. We never do surgery to remove the instrumentation. There's no reason to do that. That's just an additional surgery, but it's not at risk anymore.
Okay, great. Okay, someone's asking about the optimal epidural injections protocol. Would you have these injections sooner to relieve pain or closer to a bigger event? Like say for someone who's traveling, yeah, okay.
Absolutely, yeah. So the timing of epidurals, I think, has two phases. So I've seen patients where their symptoms are so severe that they can't actively participate in physical therapy. So then you would say, look, start with an epidural, see if that gets you maybe 50% pain relief, and then you can do the physical therapy, really participate in the exercises, and hopefully that combination of benefit will get you over the hump to where you're now functional and having a reasonable quality of life. But most typically will recommend holding off on an injection unless your symptoms have gotten bad enough that you're considering something like surgery. And the reason for that is the epidurals aren't preventative. So it's not like you can take an epidural when you're not very symptomatic, and that will prevent you from developing symptoms down the road. If you don't have significant symptoms, the pain management people will typically recommend not taking it at all. And that's because from their standpoint, they can only give a limited amount of injections per year. Number one, because they're going into the canal where the spine is located, so they don't want to create scar tissue. They don't want to do additional procedures that are unnecessary, and they don't want to potentially take away their ability to respond with a procedure when you actually need it because symptoms have gotten much worse.
Okay, great. Somebody's asking about it. It seems that people who have these types of surgeries or back surgeries have multiple surgeries, at least historically. Do you find that as much, or what do you think about that?
Good question. Yeah, that's a great question, actually. So I would say that is very common to see overall, and there are two factors related to that. So the first is a timing issue, meaning if you're young and you have a back problem and you undergo surgery, the surgery is taking care of the problem that you have at that moment, but it doesn't really address the fact that somebody who is young and needs back surgery probably has underlying problems with their back overall that will continue to happen across levels where you didn't operate. So meaning if you're prone to developing arthritis when you're 30 and you need a surgery for a disc herniation or for a bone spur, then the likelihood is you're going to continue to be active for another 20 or 30 years at least, and you're going to be more prone to developing arthritis at other levels, which will bring you back for exactly the same problem. The second issue from our perspective is when we're doing surgery to address the problem that is causing a limitation in regards to function. But typically the person will have other structural problems in their spine that we don't want to address because number one, that lengthens the time of surgery, that lengthens the recovery of surgery, and the benefit of doing those additional levels is very unclear because they may not have compression of the nerves at that moment. But when that progresses, and now this new level that we saw a little bit of a problem on 3 years ago, but really wasn't compressing a nerve, becomes active, then you've basically reset the whole process because you're essentially dealing with a new problem. In theory, you could have anticipated that that might have been an issue, but what I always tell patients when it comes to the spine is even though everybody's spine slowly degenerates, there's no way to predict how fast that's going to happen. So we can't look at an MRI from 2 years ago and say, oh, I knew back then that you were going to be in my office a year and a half later, ready to sign up for surgery, because I've seen patients with terrible looking spines in their 80s, and they say, yeah, I've had a couple of days of back pain, but otherwise I've really never had a problem with my back. And I've seen patients with a tiny disc herniation, barely touching a nerve, and they're in screaming pain and miserable, and nothing helps, physical therapy, injections, and they're having surgery in the hospital because they can't even get out of the hospital. So everybody's nerves are very different. And unfortunately, we don't have a computer model that will tell us, we can predict that in 6 months, 3 years, or 10 years, that other level that we're seeing a little bit of a problem with is going to be enough of an issue that we need to do additional surgery.
Okay, thanks. I'm going to kind of start to combine these questions because there's so many. Someone asks about, I have neurogenic claudication of the left leg, right?
Yep.
Two steroid spinal injections have not helped. Should I consult with a surgeon at this point?
Yes. So that's the perfect scenario to consult with a surgeon because most patients are allowed to have 3 injections, and there are a couple of different ways of doing the injections. But if you've had 2 in a row and 0 benefit, typically the pain management person will say, look, it's not worth it doing the 3rd because I'm going to be using the same medication. I'm going to be using one of the 2 techniques to get into the space. And why would the result be any different than last time?
Okay.
So,
where does losing weight and age fit into requirements for surgery?
Good question. So with the minimally invasive approaches, weight limitations are much less since the surgeries are shorter and the tubes come in all lengths, so we can get to pretty much any location in the spine. But I think most surgeons would say if weight loss is a reasonable goal, you should probably try it first prior to considering the surgery. The big catch-22 that most patients run into who have spinal stenosis is because it affects your activity level and therefore you become more sedentary. You see your metabolism slow. And so even if you try and diet, you just can't restrict the caloric intake sufficiently to lose weight. And so that's a scenario where if you can't lose the weight, the surgery can actually help get you back to being active and affect overall health outcomes. But yeah, generally speaking, from our standpoint, trying weight loss beforehand, before the symptoms really get severe, is probably the best option. But weight is not a limitation to doing the actual surgery. Age also not a limitation. I'd say most people consider age a limitation in the sense that for themselves, they may say, look, I'm 85, there's no way I'm considering surgery. But I've seen very active 85-year-olds who will come in and say, look, if I can't play tennis, 2 times a week, if I can't, go 9 holes with my friends, if I can't go and walk a couple of blocks in New York to the theater, that quality of life is unacceptable to me. So those patients generally are healthier just to begin with, and they've established a quality of life where they say, this is my threshold. And so anything below that is unacceptable. And so usually they do pretty well with surgery. But it's as people get older, they kind of self-select out of it because they're just like, I wouldn't do surgery at my age. But it's not a strict limitation.
Okay, great. Also, just along that same lines, if you can, then would you suggest exercise to kind of get prepared for this, or would you suggest people not exercise if they're?
Oh, good question. Yes. So the 2 questions that I get in regards to this is doing exercise to prepare for surgery. So absolutely. And that's because, as you get sedentary and the muscles get weak, even after the symptoms resolve after surgery, you can find that things like walking long distances are difficult because you've lost the stamina. So even if physical therapy doesn't help, certain exercises like riding a bike typically don't provoke symptoms. So patients should be doing that even prior to surgery to kind of keep the leg muscles strong. Patients will generally say that being in a pool where they've got more buoyancy will allow them to stand and kind of do exercise, sort of aqua therapy kind of things. So we'll always encourage patients to do that. It's not strictly required in order to do the surgery, but it's helpful for the recovery after surgery for sure. The other thing that I get is patients will say, even though it hurts, should I continue to walk? And the way I would put it is, you shouldn't cause yourself to be in pain, but you want to try and resist the urge to be sedentary because that's what impacts your health overall. So if it means, you have to take multiple short walks, if it means you have to incorporate these other types of exercise that I mentioned, it's important to do that. But the idea of just like gritting your teeth and walking the half mile, even though by the end of it you're crawling, that doesn't make a lot of sense.
Good. Okay. So this is a biggie. A couple of people are asking this. Is it possible to have cervical spine stenosis at the same time as lower back stenosis? And can you treat them, including with surgery at the same time?
Good question. So it is, yes, it is common, in fact, to see that. I mean, there's multiple situations where I'll see a patient for lower back stenosis, and they'll start complaining to me just when I'm asking them questions about symptoms in their arms, and we'll get imaging up there, and all of a sudden we find out that they have a problem in their neck as well. Generally speaking, stenosis in the neck is more critical than stenosis in the lower back, and so that will generally take preference. There are theoretically ways of doing both surgeries at the same time, but it lengthens the surgical procedure significantly. And oftentimes the amount of time under anesthesia is the biggest risk factor for complications. So most surgeons, unless there is a very compelling reason to do both at the same time, will advocate to stage those surgeries because it's much safer to do two-hour surgeries separated in time with a period to recover between than to do a 4-hour surgery under anesthesia where you're operating on both areas.
Right. Thank you. Question about, sorry, there's more. That's okay, doctor.
No worries.
What is arthritis? Okay, hold on. Arthritis actually that causes the narrowing of the canal. What is that? Is it extra bone growth or spurs? Do you know?
Absolutely, yes. So generally speaking, arthritis refers to inflammation of any joint. In the spine, arthritis manifests as bone spur formation, but it also manifests as overgrowth of the soft tissues or ligaments that provide the capsule for the joint. So what I would say is probably 75% of the time, it's actually the soft tissues like the ligaments and the tendons around the joint that become bigger and push into the canal where the nerve is running. And probably 25% of the time, it's an individual bone spur growing from the front of the spine, for example, that will push in backwards towards that. So it's 75-25.
Okay, and epidural injections, faceted injections, and are they the same as spinal stenosis injections? Just people just want clarity around that.
Absolutely. So an epidural steroid injection is injecting steroid into the space right outside of the sac where the nerves are running, but in that actual canal. So that is for things like disc herniations that are compressing a nerve and giving you sharp shooting pain down the legs, and for stenosis symptoms, because there you're trying to reduce the inflammation around the nerve and in the nerve itself. Facet injections are injections into the joint. The facet joints are the paired joints on the side of the spine. So that's more for pure back pain. So that's not really for stenosis. That's for patients who have arthritis in the joints, and that arthritis is causing pain. And so you're trying to numb the nerves that go to that joint and potentially reduce the inflammation around the joint instead. So it's different targets. Epidurals target the nerves that are running into your legs. Facet joints are targeting the joints that are the source of pain because they have arthritis in them.
Is it normal for any of these injections to take a while to kick in? Like
yes,
okay.
Absolutely. So most pain management doctors will say, look, give the epidural steroid injections at least 2 weeks to see the maximum benefit. So they won't recommend doing a second injection for at least 3 weeks after the first procedure to give you time to see any powerful anti-inflammatory effects that happen. The facet joints, it's usually faster, to be honest with you. There you usually see the benefit within a couple of days. And if you haven't seen the benefit, they can try and target other joints, because somebody who has arthritis in one set of joints in their spine probably has arthritis in other sets. So they'll sort of work in a stepwise systematic fashion to try and figure out which pair of joints is causing the issue.
Okay. And what is an ablation as opposed to a facet injection? Is that?
Good question. Yeah. So what's called the medial branch is there's a little tiny branch of the nerves that exits at each level that supplies sensation to the joint. So a facet injection is you're just injecting into the joint to reduce inflammation. An ablation is where you essentially try to kill the nerve that goes to that joint so that you don't feel the pain that's coming from the arthritis from that joint. So it's similar in the sense that you're trying to target pain arising from the joints, but in one area, you're trying to reduce inflammation. So just like when your knee hurts and you get an injection of cortisone into the knee, that's essentially what a facet injection is in your back. The medial branch block and the radiofrequency ablation is when you try and deaden the nerve to that facet, because it's not an important nerve. It doesn't go into the legs, doesn't control any motor function. And so it's a way of sort of bypassing treating the actual structural problem by just deadening the nerves so that you don't feel the pain sensation. Unfortunately, it only works in selected cases. So they will always do a test where they use lidocaine or novocaine to deaden the nerve on a temporary basis. And if you have relief, then they'll kill the nerve. Unfortunately, also the nerve grows back, so it's not a permanent solution, but it can provide anywhere from 6 months to a couple of years worth of relief. And the hope is that if the nerve comes back, the pain doesn't.
And somebody also is asking about, they were advised by the Valley Pain Center to continue use of naproxen, all the over-the-counter or pain type meds, and try to limit epidurals. Is that like, is there a level where you would suggest they start to think about possible?
Yeah, absolutely. So I would say if the medications are working, then you should continue doing that. Okay. If the medications are essentially what we would consider a placebo, meaning, when I ask patients and they say, yeah, I think it might work a little bit, I think it might cut the edge off, but I'm not really sure if it's actually doing anything. That's the point in which you say, okay, it's time to think about something else. The problem that patients will run into is because these are activity-based problems, and also one thing that I didn't mention is that the course of this varies, meaning you can have somebody who has really bad symptoms for a few weeks, and then for whatever reason, all of a sudden the symptoms aren't nearly as bad. Some people will say the weather affects it. Some people will say, their baseline level of activity affects it, meaning if they're not doing anything too strenuous, it's not too bad. But if they decide to go and play golf, then for the next week, they're shot. So because there's all of these fluctuations, when they're talking to the doctor, they may say, 25% of the time it's bad, but the rest of the time it's actually not terrible. And from the doctor's perspective, they say, well, that sounds great. So I don't want to do a procedure on you. Just keep doing what you're doing and trying to avoid the pain. But when you're actually living life and it's been 6 months or 2 years, and you're like, this overall quality of life just isn't for me. So it's hard for the doctor in that, 30-minute or 45-minute session to get a full flavor for what your everyday life is like. But for yourself, if you're really seeing that, the medications aren't helping, then you got to express that to the doctor, because they're always going to err on the side of not doing a procedure if they think that your quality of life is satisfactory.
Okay, great. Just a couple of questions about osteoporosis, which I'll put into one question. Does osteoporosis affect fusion surgery, and are epidural steroids a problem for osteoporosis to your knowledge?
Yes, good questions. So we know that outside administration of steroids, generally speaking, leads to bone loss that can contribute to osteoporosis. The amount of steroid that's given with an epidural steroid injection is pretty small, but if you're thinking about somebody who's managing their symptoms over an extended period of time, potentially years, I've had patients who've been seeing pain management for 10 or 15 years with periodic injections who are, living a reasonable quality of life. At some point, you have to imagine that starts to impact the bone quality. That being said, it's probably not a local issue, meaning it's not like the steroids are reducing the bone density where you do the injection. It probably works just like steroids that you take orally, where it's the overall burden that affects your overall level of bone quality across, multiple areas. Generally speaking, the osteoporosis is a problem if you're thinking about a fusion, but it's a manageable problem. When you're thinking about fusing bones together, the main concerns that you have is the bone that we're putting the screws or the instrumentation into strong enough to hold? So, if you put a screw into drywall versus a screw into brick, that the screw itself may be strong, but the interface between the drywall and the screw is much more likely to loosen over time. And then the other thing you have to think about is, if this person has osteoporosis, how likely are they to grow new bone in the absence of giving medications or other what we call adjuvant therapies to help them produce bone? Because again, the way that you have a successful fusion is that your bones grow together. If you have osteoporosis, that's a big problem. And then the final issue from our standpoint when it comes to osteoporosis is when you lock two bones together, you're putting stress on all of the structures around it. So if you have weak bones around where you did the surgery, then that can cause problems at other levels. That can create fractures and stress fractures and compression fractures, in somebody who has pre-existing osteoporosis.
This is great. And finally, somebody's asking about lumbar stenosis. They've been diagnosed, never severe, but still concerning because of some weakness. Is that someone that should probably see you soon?
Yes. Any signs of weakness absolutely needs a surgical evaluation. You might be that 1 in 100 unlucky person who has, a particular nerve that's just a little bit more sensitive. The most common kind of weakness pattern that you'll see in patients with lumbar stenosis, and again, exceedingly rare, but you'll see things like a foot drop where they have difficulty moving their toes or moving their foot, which can affect their ability to walk because they're always tripping over their foot or they're always misjudging where they place their step. And that can lead to falls, hip fractures, etc. So yeah, any signs of true weakness definitely deserves an actual surgical consultation.
Okay. Wow, this was wonderful. I think we could do a whole nother lecture on cervical
Absolutely.
issues, and we will, folks. We definitely will. A